As we start the new year, share your $40 one-time gift when you text the word GIVE to 83393. GIVE to 83393.
British motorists drive on the left, Americans on the right. There's a perfectly logical explanation why, and we will share it on the Old Farmer's Almanac Radio Report.
You owe over $10,000 in back taxes. You've called every tax firm out there. They all say the same thing, making promises they never keep, and you're sick of it.
Good morning. You're listening now to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you. Mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. And good morning. This is Dan Gatis, and thank you for tuning in, sharing the morning with us, being a part of a Medical Monday, February 8th, 16 degrees and rising. It will go up to about 29 degrees today. Mix of sun and clouds. And tonight, cloudy with an 80% chance of some snow developing after midnight. A low of 17, 1 to 3 inches possible before sunrise. And Tuesday, 90% chance of snow during the morning, then bringing some lingering snow showers during the afternoon. A high around 30 and another possible 1 to 3 inches of snow on Tuesday. We'll be right back after these messages.
You're listening to Kingston Community Radio on WGHQ Kingston. On your radio at 920 AM and 92.5 FM, and also online at mykcr.org.
Hi, I'm Danica Patrick. Watching my nieces grow, play, and learn is amazing, but not every child gets to be carefree. 1 in 6 kids in the U.S. are hungry. This breaks my heart, and it's something that Feeding America is working to change. Each year, the Feeding America network of food banks rescues billions of pounds of good food that would have gone to waste and gives it to families in need. To help, visit feedingamerica.org.
Brought to you by Feeding America and the Ad Council.
Man, do I love card night. You ready, boys? You got a king?
Go, fish dad!
Oh, come on! This is WWE superstar Titus O'Neil. It only takes a moment to make a moment. Take time to be a dad today. Learn more at 877-4DAD-411 or visit fatherhood.gov.
Brought to you by the U.S. Department of Health and Human Services and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
The Home Energy Assistance Program can help make winter a little warmer this season, with financial grants to eligible households to help pay heating or utility bills. Are you in need of assistance or know someone who is? Find out more about the benefits and eligibility requirements of the HEAP program by contacting your County Department of Social Services or by visiting the Assistance Program section of Central Hudson's website, centralhudson.com. Just don't. If you see a low-hanging or downed wire, don't touch it. Don't move it. Don't go near it. Don't drive over it. It may be a power line carrying an electric current strong enough to kill. But here's what to do. Stay at least 30 feet away and call 911. Central Hudson will take care of the problem. If you come close to a wire, shuffle away with small steps and watch your step. Wires may be hidden in fallen tree limbs or near water. Your safety matters.
Hi, this is Dina Roy from Hurley, and I support the Kingston Community Radio, and so should you.
And you're with us here at KCR, Kingston Community Radio, WGHQ 920 on your AM dial, 92.5 FM, and streaming online at mykcr.org. 845-331-9255. Today is Medical Monday, and please call in. It is 7:06 a.m. We're getting a minute or two late start this morning all around, but here we are, and we are here with you. And so let's get to the on-air studio with Dr. Eric Stanberg. Welcome, Doctor.
All right, welcome to this morning's show. I'll be here from 7 a.m. to 9 a.m. Robin will be joining me, and we do have a special guest calling in. Her name is Dr. Lisa Curcio. She is a surgeon, but more specifically a breast surgeon. And I was thinking about how to prepare for having this guest on. You know, a couple themes I think we have on Medical Mondays. One is prevention, and we try at the same time we also try to talk about evidence-based medicine. What are the current recommendations, and why are things recommended? And certainly how to screen a woman for breast cancer has come up a lot. And I have my own questions to ask Dr. Curcio, so I look forward to doing that. It is a cold morning, by the way. I had 9 degrees. What did you have?
16 on the way in.
Yeah.
I haven't double-checked it, but that's usually the car... Usually the car thermometer is a little higher than
it is nice
what
to
it
have,
really is. Gives you a clue, though.
It is nice to have a hint of sunlight as I drive in, though. I'll say that.
Yeah.
Days are getting longer.
Yeah, there was a nice sunrise this morning.
Right.
Yeah, on the way.
And we're also going to talk probably about in the second half of this morning's show just about some general medical topics. And, of course, we'll do our COVID update in the second part of the show. So anyway, please feel free to call in if you have any questions. Let me give you the phone number. I think I finally have it right here. Right? What is the phone number, Dan?
331-9255. 331-9255.
Okay, great. All right. So in the meantime, what else is there to say? Again, we're going to focus on COVID in the second half of the show. There is some good news in the sense that the numbers are down a little bit, and also the availability of the vaccine will continue to improve. I heard on the radio, just waking up myself this morning, that it's estimated that 9% of the population has had at least one dose of the vaccine, and I think you're going to see that exponentially increase over the next few weeks. I also would be lying if I had my second dose about a week and a half ago now. And yeah, there are side effects, and a lot of people are getting them. So we should talk about that and try to just keep that in perspective. And I think being prepared for them is probably the most important thing. Because I'm concerned. I'm concerned that people are going to not get the vaccine because of everything that's been heard or said about it. So we're going to talk about that. Also going to talk a little bit later this morning about dysphagia, which is a fancy word for swallowing difficulties. And finally, I think we should give an update on the state of telemedicine. I think that's an interesting topic. I think Robin and I were ahead of our time with that topic because we were talking about it before COVID and trying to keep it in perspective. And I think I'm picking up on a little bit of a trend that the novelty has worn off and that people are kind of preferring to come in. A mixed bag. I think some people are still welcoming it, and it's how they choose to do things, and other people find it's more difficult than just coming in for an appointment. So I think it will always have its role in how I practice medicine. I just don't think it's going to be the dominant force that it has been held up to be. Dan, have you had any exposure to telemedicine?
Only in regard to the portal. That's oftentimes an easy way to communicate with and about your appointments that you already have scheduled. It's very convenient.
The portal can be a very useful way to communicate with me. And sometimes people put a little, as I say, TMI, too much information in it, and it's. I think
you can't deal with just in text form,
right?
In mail form.
Well, it's not that easy, right? And
sure.
So that's something for
it's
people.
Better than too little, I suppose.
Better than what?
Better than too little information.
I guess so.
Yeah.
I guess so. And if your provider's response is to make an appointment, so be it. Because some things we've all learned about the limitations of telecommunication, texting, and how things can get misconstrued with that. So there's no substitute to a direct conversation. All right, so I think we have on the line our guest for the morning, Dr. Lisa Curcio. Good morning.
Good morning.
Thank you for calling in.
Thank you for having me. I'm excited to be here.
Anyway, let's see. So I'm pronouncing your name correctly, right, Curcio?
Yes, it is.
All right. So Dr. Curcio is new to our area. She is with the New Vance organization, although I'm sure she and I will agree that we try to practice kind of take care of the entire population, all the patients in our community as well, and that you are a surgeon and more specifically a breast surgery specialist. Is that correct?
That's correct. I am. I underwent additional training after general surgery as a surgical oncologist, which is a cancer surgeon and a subspecialist in breast cancer surgery.
Okay. I always like to start the interview by just kind of asking you to tell us a little bit about yourself, how you wound up in Rhinebeck. I understand you relocated recently from California.
Yes, correct. So my route to Rhinebeck has been somewhat circuitous.
Okay.
I'm actually a native of northeastern Pennsylvania. Grew up in the Scranton Wilkes-Barre area. And went to undergraduate school there. Then went on to go to medical school and residency at George Washington University in Washington, D.C. And then I went to California where I did my surgical oncology fellowship at City of Hope in Duarte, California. From California, I actually had a health professions fellowship. The United States Air Force paid for medical school for me. And I paid back my obligation at Keesler Air Force Base in Biloxi, Mississippi. So I spent 4 years in Biloxi, Mississippi. Then returned to Southern California, where I spent about 19 years practicing surgery, and particularly over the past 15 years, breast surgery.
Okay. And the final chapter is how you wound up in Rhinebeck.
Yes, so I really wanted to get back close to my family. Mm-hmm. I was kind of the only wanderer so far away, and I decided when this opportunity came around to grow this program and to build the breast program, I really found it a great opportunity to do something meaningful and to get back closer to home.
Okay. And I thought you also chose to live in 9-degree weather over the rather than the weather of Southern California.
The weather in Southern California is amazing. There's no doubt about that. But it is Southern California.
All right. So, how are things going so far? Since now that you're here.
So, I have to say that the support from administration at Northern Dutchess Hospital has been amazing. They have really invested in growing this program, including purchasing, I think it was like $250,000 worth of equipment to really bring our program, to state-of-the-art care. I think our biggest challenge is I joined the group in October in the middle of the pandemic. And so it's been, somewhat challenging getting the word out that we do have a breast program now at Northern Dutchess, because in the past, I think patients were referred out. And so we're really working on trying to make people aware of the fact that we do have a quality program at Northern Dutchess.
Okay. Well, I have my good friend, my special friend, Robin Baker, is also our co-host, and there she is. Say good morning, Robin.
Good morning, Doctor.
Okay, and then Robin is here kind of to make sure we don't get too jargony in our discussion.
Patient perspective.
Yes.
Absolutely.
But a couple themes we have on the show, and I'm a primary care doctor, so we tend to talk a lot about prevention, and we also tend to talk a lot about evidence-based guidelines, and breast cancer is one of these topics that breast cancer screening prevention I have questions about. When I was in medical school and residency, the recommendation was for women to get a baseline mammogram at 35 and then start getting annual mammograms at 40. I still kind of do the 40 guideline, but I read and I understand that there are recommendations out there to recommend 50 and to recommend screenings every 2 years instead of every year. What's your take on that?
So I do believe you're not the only one in the medical profession that is confused, because if you look at the guidelines from different societies, they're all over the board. And so it's really hard for patients to know what to do when the medical profession, different professions and different subspecialists are very kind of discontiguous on what the recommendations are. The American College of Surgeons the American Cancer Society recommends starting at least at age 45 with yearly mammograms, and they suggest that women should be given the opportunity between ages 40 to 45. And then the controversy becomes, should we go at age 50 to every other year? And that's what the task force seemed to recommend, that yearly wasn't needed and that every 2 years starting at age 50. Our society, the American Society of Breast Surgeons, still feels very strongly that we should start screening at age 40 and we should continue yearly screening moving forward. Another controversy that we see a lot is when to stop screening.
That's a good question.
And there are some organizations, including the task force, that recommend stopping at a certain age. But I think that as our population ages, and I think our population is aging better, I mean, they're healthier in their 80s and 90s, by stopping screening, say, at age 75, what that's allowing is these women to develop more advanced breast cancers that they feel and then be subjected to, things like chemotherapy and more radical surgery sometimes. So I think that a lot of the organizations are starting to say, you got to look at the overall health of the woman, what their comorbidities are, what their other medical problems are. And if they have a life expectancy of 10 years, they should be getting screening.
Okay, I feel kind of vindicated. In primary care, for example, the recommendation for colonoscopy, screening colonoscopy, is kind of a hard stop at 75. And for breast cancer, it's individualized. And that is sort of the way I counsel my patients in their late 70s and 80s, particularly in the context of like a wellness visit. I really encourage people to have these regular visits with their healthcare provider, because this is the time to discuss these issues, because as you very clearly made, there's no clear answer. It's an individualized decision on when a woman should stop getting mammograms.
Right. And I think you're correct, and it does have to be individualized, and patients should be educated what are the benefits, what are the risks, and then they participate in a shared decision-making process.
Shared decision-making, yes. That is, again, this is part of what we talk about a lot. I had a couple other basic questions. What about the role of a breast self-exam? Again, it kind of makes sense, right? But then I read that it's certain sources say not to do it, which is a very peculiar recommendation, because it makes sense for somebody to check themselves. What do you think about that?
I absolutely agree that breast self-examinations are essentially important, particularly in the age group of women before they're screening, because we do see women not uncommonly present with a self-detected breast mass. I think the American Cancer Society came out many years ago discouraging breast self-examinations. And again, I think that was a grave disservice to women. I think knowing what your breast feels like And knowing if there's a change is just another part of being proactive and preventative in your overall health. And I strongly encourage breast self-examination.
All right. I think I kind of just jumped right into the topic of mammograms. So perhaps we should just kind of review for people what puts a patient, a woman, at risk of breast cancer. What are some of the common areas that would make someone more concerned about the possibility?
Okay. So certainly, the big risk factors are being female and getting older for breast cancer. But if you're looking at what are the other things that can increase risk are obviously family history. Women who have never had children or had their first live birth after the age of 40 are at increased risk. Women who have been on many years of hormone therapy are at increased risk. Women who have had biopsies that show atypical changes are at increased risk for breast cancer. And there is some data to suggest that women who continue to have dense breast tissue, particularly into menopause, may be at increased risk for breast cancer.
Okay. I remember a couple of years ago there was a lot of talk about breast cancer pockets, like particularly Long Island, for example. Is that something that that you recall, or is that something that's relevant?
So I think that you do see sometimes kind of clusters, and the question becomes whether that's just related to women that have similar demographics being in one area, or perhaps some exposure, women who grow up in a certain area, some kind of environmental exposure.
Right.
But I don't think we really understand the epidemiology when we see clusters like that. I think it needs further research. But you do wonder about some kind of exposure.
Okay. I have a couple other questions kind of back to the screening. We talked about the mammograms, but it's not unusual for a woman to have an ultrasound. I guess the first question really is specific for screening purposes. Is that ever relevant?
Yes. Our society recommends that women who are normal risk, they be screened, obviously, with 3D preferable mammograms every year. But if you have dense breast tissue, you should talk to your physician about supplementing that with things such as ultrasound. Because we know that women who have dense breast tissue, that's where you're going to get your false negative with the mammogram. That's where you're going to miss something on the mammogram that could perhaps be picked up with an ultrasound.
Okay. And for some people to understand, a lot of times those tests are used kind of in conjunction each other to kind of, you might see one on the other and not on the other, and that helps kind of formulate what to do next for the patient.
Correct. They're certainly additive when used in a screening method. Obviously, if you have an abnormal mammogram, oftentimes the recommendation is for additional imaging like ultrasound to further evaluate that mammogram. But in terms of screening, they can give different information, particularly in a woman who has really dense breast tissue and where a mammogram might be a little bit less sensitive.
Okay. This comes up a lot in primary care as well. What about the idea of breast MRI? When is that relevant?
Excellent question. It's interesting because the interest in breast MRI is different geographically. In Southern California, we were huge users of breast MRI. And I think, that can be a drain on the healthcare system. So I think it does need to be used judiciously. The patients that I consider using a breast MRI in are certainly patients who are at increased risk. For instance, patients identified with the BRCA mutation, or patients whose lifetime risk is much higher than the general population who have, for instance, dense breasts. Sometimes I'll alternate ultrasound with breast MRI in addition to mammogram. And sometimes we use it in challenging cases where mammogram and ultrasound don't give us the information we need. We will supplement at times with MRI.
Okay, and then you briefly mentioned genetic testing, because that is also something that comes up a lot for individuals.
Right. So women who have a family history of breast cancer, in the past, they would just be waiting for the shoe to drop. But in this day and age, we can actually test patients to see if they have a genetic predisposition and then be proactive. There are things we can do to reduce the risk of inevitably developing that breast cancer if they did inherit that particular genetic factor. So it's important to test people, if they have a significant family history, and even more importantly, if their family members that had cancer are still alive, to test those family members so we can see what's the particular gene that may be responsible for cancer in their family, and then identify whether the patient who doesn't have cancer inherited that gene and is at increased risk. And the good news is if they did not inherit that increased risk, they don't have, that family history no longer pertains to them. So you can exclude additional imaging in some of those patients where we exclude that they have the gene that's causing cancer in their family members. So it's a very powerful tool, and it has to be interpreted correctly in the context of family members with cancer. It's important to, carefully educate a patient what those test results mean.
And are you specifically referring to what's called the BRCA gene? Are there other genes that are tested for?
Yes, the BRCA gene was the first identified hereditary breast cancer gene. There's the BRCA1 and BRCA2 that if a woman inherits this gene and they haven't had cancer, their lifetime risk to get cancer could be as high as 80%. But nowadays we've identified additional genes. And so when I see women and they have significant family histories, sometimes we will test for up to 84 genes that have been identified to be associated with hereditary cancer syndrome.
It's changing so much from my perspective, when I've been around long enough to remember. So what is a significant family history? How would you define that? I mean, I say to my patients, the closer the relative and the younger the relative, it makes it more significant. I mean, but some people have, an aunt who had breast cancer in her 80s, something like that. What do you think?
Right. So I think the number of relatives is important, and yes, the closeness in terms of relatives. But I also think it has to be looked at with a grain of salt. I always kind of quiz patients about 3 generations of their family history. Because, for instance, say mom was an only child or she only had a brother, sometimes that family history has to be really kind of teased out from prior generations. And so family history of breast cancer in multiple relatives, yes, particularly in younger age. And what's really significant, it stands out, is if someone was diagnosed premenopausally with breast cancer or had bilateral breast cancer. Sure. Another risk factor could be a family history of ovarian cancer, because particularly with the BRCA1 and 2 gene, ovarian cancer is at increased risk. And it's important to look at dad's side of the family too, because we used to think, and I learned in medical school, that breast cancer risk only came through the mother's side. But the reality is, as we understand genetics now, 50% of our genes come from our father, 50% come from our mother. So you have to go back and look at the females in dad's family as well as the females in your mother's family.
Okay.
Is there a significant risk to men, too, for breast cancer? And is there ever? I don't think there's any routine screening for men, is there?
There is no routine screening. And the risk, in women is 1 out of 8 women will develop breast cancer. In men, it's 1 out of 800. So the risk is much smaller in men, but it is there. And interestingly, male breast cancer is more commonly associated with hereditary syndromes because, for instance, the BRCA1 and 2 gene can be associated with an increased risk for male breast cancer. So men do need to be kind of cognizant of their breast exam when they're showering. If they feel lumps or have new symptoms, they should always bring that to their primary care doctor and discuss, and then additional imaging would be ordered. But yes, male breast cancer is real. And generally, as a breast surgeon, we usually see several cases every year of male breast cancer. And there commonly is a delay in diagnosis because of the lack of understanding that these symptoms are significant in men.
We actually have to go to a quick break. I don't know how much time we have with you, but can you come back after the break?
Absolutely.
All right, great. Thank you for doing this.
No problem.
Okay, thank you, Dr. Lisa Curcio, and thank you, Eric Stanberg and Robin Baker. We will be back in just a couple minutes after these station breaks. You are listening to KCR, Kingston Community Radio, AM 920 and 92.5 FM, WGHQ. Monday, February 8th, and it's 11 degrees right now here in uptown Kingston. Today, a mix of clouds and sun, a high of 29. Tonight, cloudy with an 80% chance of snow developing after midnight, a low of 17, 1 to 3 inches of rain of snow expected, and Tuesday 90% chance of snow during the morning, and then lingering snow showers during the afternoon on Tuesday tomorrow, and a high around 30, 1 to 3 inches of snow expected tomorrow as well. We'll be right back after these messages.
You're listening to Kingston Community Radio on WGHQ Kingston. On your radio at 920 AM and 92.5 FM, and also online at mykcr.org.
The Home Energy Assistance Program can help make winter a little warmer this season, with financial grants to eligible households to help pay heating or utility bills. Are you in need of assistance or know someone who is? Find out more about the benefits and eligibility requirements of the HEAP program by contacting your County Department of Social Services or by visiting the Assistance Program section of Central Hudson's website, centralhudson.com. Don't. Just don't. If you see a low-hanging or downed wire, don't touch it. Don't move it. Don't go near it. Don't drive over it. It may be a power line carrying an electric current strong enough to kill. But here's what to do. Stay at least 30 feet away and call 911. Central Hudson will take care of the problem. If you come close to a wire, shuffle away with small steps and watch your step. Wires may be hidden in fallen tree limbs or near water. Your safety matters.
Hi, this is Dina Roy from Hurley, and I support the Kingston Community Radio, and so should you.
You're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM, and this upcoming portion of Kingston Community Radio is brought to you by Central Hudson. It's Monday, February 8th, and 7:33 a.m., 11 degrees here on this Monday morning. And let's get back to the on-air studio with Dr. Eric Stanberg, Robin Baker, and our guest, Dr. Lisa Curcio. Welcome back.
All right, thank you, Dan. Welcome to the second half hour of this morning's show. Our guest is Dr. Lisa Curcio, who is a surgeon and a breast cancer surgery specialist, now practicing out of Rhinebeck Hospital, where we are developing a breast cancer program. And we have been talking about a lot of screening questions, and I did want to make a little editorial, in reference to COVID. It's really important that people not delay their routine care because of COVID. People should still continue to have their appointments and recommended screening tests, and I just wanted to say that as a primary care physician, to not kind of gamble with one thing while you're worried about something else. Dr. Kersey, you still on the line?
I'm still here, yes.
Okay. We talked about screening, and we talked about breast cancer in men. We talked about when to start screening, when to stop screening, the role of mammogram, ultrasound, and even MRI, and also genetic testing. Just what happens if something is seen on a mammogram? What would you recommend? Go ahead.
Well, that's okay. So I think that, automatically people believe that once they get called back for an abnormal mammogram that it's going to be cancer. But that's not necessarily the case. Sometimes the patient will be called back and they'll do additional mammograms Sometimes they do what they call magnification views, where they're looking for maybe little specks of calcium to see if they look suspicious. Or sometimes they're compressing out, because if you have dense breast tissue, you could sometimes get shadows on a mammogram that end up just being that, just shadows. And when we compress the breast more, then those shadows go away. And then sometimes we do additional imaging like ultrasound. And so sometimes after that additional imaging, everything clear, is found to be fine, and they go back to their yearly mammogram. Sometimes the recommendation will be maybe there's something there, but it's not worrisome enough to biopsy, so they'll recommend a 6-month follow-up. And then other times they'll say, we see something, let's do a biopsy. And again, a biopsy does not necessarily mean that there's cancer. In anywhere between 30 to 50% of biopsies, there will be benign changes, or maybe some changes that we need to follow, but not necessarily cancer.
Okay, interesting. And what are some of the causes of breast lumps or breast abnormalities that are not malignant, not cancer? Because these come up a lot too.
Right. So fibrocystic changes is probably the most common. We used to call it fibrocystic disease, but the majority of women have some sort of fibrocystic changes, and they could lead to lumps or abnormalities on a mammogram. Breastfeeding can sometimes cause calcifications to be deposited on the mammogram that'll be there. And so that's why it's so important to get the yearly mammogram, because you can look back and say, okay, these calcifications have been there for 10 years and they haven't changed. So we know that they're not anything of concern. Or on the other side, these calcifications have been there, but this year they're getting more significant or more worrisome, and hence, needing a biopsy. In the younger population, the most common cause of a breast lump is an entity called a fibroadenoma, which is an area of breast tissue that becomes mass-like, similar to like a fatty tumor called the lipoma. A fibroadenoma in the breast can create an actual lump that you can put your fingers around. And these are commonly seen in women in their 20s and 30s, and very benign cause that can oftentimes be followed as long as they're not growing rapidly.
That's helpful to point out. So what if a woman does have a biopsy that comes back positive for cancer? What would be the next steps?
So the next steps are for the women will be referred to someone like myself, a breast specialist, who would see the patient, and we're usually, as breast surgeons, the front line that kind of coordinates the care. So we evaluate them. As I mentioned, we do a very extensive family history. Once you've been diagnosed with breast cancer, there is a higher risk that you may have some genetic predisposition. So we decide if genetic testing is necessary. And at my office here at Northern Duchess, we do genetic testing right in the office at that first visit. Because it may affect the woman's risk to get a second breast cancer after we cure the first breast cancer. Okay. So that information early on is very important to get. And then we determine whether the patient is, what surgery the patient is a candidate for, and discuss those different options with the patient. So again, there can be shared decision-making between myself and the patient in regards to what surgery we would want to perform. Not uncommonly, sometimes the tumor is bigger or more aggressive, so sometimes the patient will see the medical oncologist, which we help to coordinate, to determine whether or not maybe surgery shouldn't be the first approach, and sometimes chemotherapy is the first approach if it's a more aggressive tumor or a larger tumor that we want to shrink down to be able to do a smaller surgery. So all of that kind of is discussed in that first visit, and then we kind of give the patient a written plan. Here's what we know about your tumor right now. Here are the additional tests that you need to do. Here are the additional physicians you need to see. And then we regroup after a week or two to determine, okay, now what's your definitive plan? Are we going to do surgery first? Are we going to do chemotherapy first? And maybe you see the medical oncologist after surgery.
Okay, and I think the importance of team care is, kind of comes down what you're talking about to help with this. When someone has a diagnosis like this, using
absolutely. The breast cancer is one of the specialties that really requires what we call a multidisciplinary approach. And for instance, facilities like Nuvance, we actually have a multidisciplinary breast conference where we discuss cases every week. And there, the pathologist is there, the radiologist, the breast surgeons, the medical oncologist, the radiation oncologist. And complex cases, we review the pathology slides, we review all the imaging, and then amongst all the different specialists, we discuss what's the best treatment management for this particular patient. So there's a lot that goes into that decision making to make the right decision, the individualized decision for that particular breast cancer patient.
Okay, I understand that, and that's good. And I think we are doing a good job of building a program and a team. Dr. Faisal Waheed is a local hem-onc specialist who recently joined Nuvance, and we also have in the Kingston Rhinebeck area Dr. Alfonso Coutinho, two oncologists, right? And then and then the team of radiologists and how important they are as well.
Absolutely.
Let's see. What was my next question? Oh, sometimes I hear stories about women getting kind of preventative or mastectomies. Just having their breast removed because their risk is so high. What is your take on that?
So I think those are very individual decisions. I think that women who are at increased risk, I follow a lot of patients like that who have family history and kind of help them to decide what's the best screening modalities for them to have. And if they're found to have genetic mutations, we talk about what their lifetime risk is to have breast cancer. And I think it's a very individual choice. If they had women who had cancer in their family and they died of the cancer, sometimes they're more willing to be more aggressive with their preventative approach, like a preventative mastectomy. And in this day and age, reconstruction has gotten so good that preventative mastectomies doesn't necessarily mean that they're going to be disfigured for their life. We actually have excellent breast reconstruction surgeons who really reshape the breast and create, a very realistic breast reconstruction product that, sometimes it is very difficult to know that patient has had a mastectomy. Now, there obviously are changes that the patient will know, but in terms of the aesthetic effect, we can actually, in many instances, create very realistic looking breast even after a preventative mastectomy.
Okay, so it's a very individualized recommendation, but it's potentially something a woman would consider if her risk is high enough.
Right. There are other modalities other than surgery, though. A woman doesn't have to be trapped in that just as their only choice. We do know in women who are at increased risk, going on medications that we've traditionally used to treat breast cancer, that actually some of those medications have been shown in studies to actually prevent breast cancer in women who are at increased risk. So again, a conversation regarding what the risk is, how high is the risk, and whether or not the patient is willing to take a medication to potentially reduce that risk. That could be a very effective modality also.
So what medication are you referring to?
So the NSABP1 prevention trial actually showed that tamoxifen was 50% effective in reducing the risk of breast cancer in women who are at increased risk. And more recently, some of the trials, the P2 trials showed raloxifene showed a reduction in risk, which is Vista, which was initially an FDA-approved medication for bone density, so less side effects than tamoxifen. And some of the aromatase inhibitors have been shown to also be preventative for breast cancer risk.
Okay. All important notes. So we talked about a case where a woman may consider something, dramatic, like a preventative mastectomy. What about the opposite? Some stories of women who have a breast cancer they're sometimes told it's a nuisance tumor, or that it can be watched, or something along those lines. What is your take on that?
A nuisance tumor? I don't know if I've ever used that term before.
Okay.
So certainly, in an older population, in a patient who has a lot of medical, say, comorbidities, we sometimes don't take those patients to surgery because the risk of surgery could be higher than the benefit. And so if that tumor is, for instance, hormone sensitive, that means it's being driven by estrogen and progesterone. We can treat that tumor medically. But maybe what you're referring to is maybe some data looking at patients with non-invasive breast cancer,
sure.
DCIS, which stands for ductal carcinoma in situ. And those patients, there is some controversy whether all of those non-invasive cancers would potentially become invasive cancer and whether or not they can be observed. I think that's a very controversial area. And certainly it's a conversation that I have with our patients who have DCIS, non-invasive breast cancer. We call it stage 0 breast cancer. But in general, we like to at least surgically excise it, and sometimes we do consider radiation. We certainly know that people who develop this non-invasive cancer are at higher risk to develop subsequent cancers, so they do need to be followed very closely.
Well, I think, that's exactly what I was referring to when I used the term nuisance tumor. You had the DCIS.
Yeah.
These are things from a primary care point of view. I'm kind of like, and it's happened, though. I have had patients come, they go down to various locations, like in the city, and they've come back with the recommendation that it can be left alone and just monitored. And then I accept that recommendation, but it's good to hear you kind of advocate for. Seems like you lean towards having that removed rather than just observing it.
Well, my experience is that sometimes patients, with this observation, they kind of like, I had 2 mammograms and it was stable. So they just fall off and then don't do imaging for a while and then come back with an invasive cancer.
Right.
I think that's a big loss for the patient because now you're dealing with a potentially life-threatening disease versus DCIS, or the non-invasive cancer. The cure rate is 99 to 100%. So why allow it to get to that point when you're dealing with a more serious disease?
Right. Okay, good point. I have some women who choose to get, instead of mammograms, they choose to get something called breast thermography. Is that something you've heard anything about?
Oh, yes. Thermography was very popular in Southern California. People are always looking for ways to avoid mammography because there's this concern that the radiation of mammograms causes cancer. But the reality is the radiation from a mammogram, is probably no more than an afternoon skiing and a mountain. It's really nowadays very negligible and less than, a transcontinental flight, the radiation you would be exposed to. Thermogram is based on temperature, and I don't believe, I am not aware of any randomized controlled trials that show that thermography is good at screening for breast cancer. I think it comes with a lot of problems because you have a patient who comes to you with just a thermogram, they haven't had recent imaging, and then you do a mammogram and it's completely negative, or an ultrasound, or even an MRI sometimes, and it's completely negative. And it's created all this anxiety, and there's no way to act on that thermogram. So I think it needs to be taken with a grain of salt, and I don't think in any way it replaces standard imaging of mammography.
All right, good points. I really discourage my patients from choosing to have that done instead of a mammogram. But it's sometimes people, they read and they get things in their heads, and it's hard to disavow them of what they already have decided to believe.
So sometimes it's hard to argue with Dr. Google.
Often here locally, there's difficulty getting patients to stay local when faced with a diagnosis such as this. We often talk about on the show, the high quality of medical care that's here, right in our midst. Of course, it's always great to get a second opinion, or we have such great, places like Sloan and places like that are, but the instance of someone going to a specialist and then coming home and then having an issue
Right.
Arise where they would have to travel long distance to actually, touch base with that doctor. I mean, Doc, how would you encourage our local patients to, I know it's a new program at Northern Dutchess Hospital, but I know we have excellent breast surgeons, doctors in this area. How would you encourage someone local to stay local?
Right. And I think that's part of what we're trying to do now with our program. I think people, it's important for them to know that we do have high quality care available to them here in our community. I think that, you go to those ivory towers, and I practiced in the community when I was in Southern California too, and I can proudly say that every community setting that I have been involved with, we provide optimal care for our patients, equivalent to what they would get at some of those ivory towers at the academic institutions. I think the difference is that we are working with their primary care doctors. They are, we're not seeing 1,000 patients a month, and so they are not a number. They are a patient when they're seen by us, and they call, and we answer the call, and we address their concerns, and we deal with them in their environment and provide a level of care that is really almost like a concierge type of care. It's individualized to the patient, and that you will not get at an academic institution. Now, if there are trials available and we do have trials, I think as a system, we really do believe, and we have worked very hard at providing quality care within the community that is really personalized to the patient.
Look, I'm a primary care doctor, and this is also my radio show. I mean, I really encourage patients to get their care locally. I've had patients, not specific to breast cancer, but something's going wrong at 4:45 p.m. on a Friday afternoon, and literally the instructions from the specialist is to call the primary. And the fact that I like when we all work together. I know my colleagues, and I know what type of care they're getting. So I encourage people to really get their care locally, unless it's not an option, which is understandable. People do have rare cancers or rare diseases or whatever. But other than that, there's no substitute for good quality local care. And that's
in terms of second opinion, I strongly encourage a second opinion if a patient wants to get a second opinion. Sometimes it can become confusing to patients, but I have all the confidence that what I'm recommending to the patient would be recommended by any reputable physician if they got a second opinion. So I think in many cases, it just solidifies the fact that they are getting that good care. But they're going to get the individualized care, and they're going to be in their community. We're going to be working with their primary care doctor to really, take care of the whole patient and not just the breast cancer. Because sometimes there are a lot of psychosocial issues that come into play with the treatment of breast cancer, and those need to be addressed too to get the patient through treatment.
All good points, and it's a general rule that a good physician is okay with second opinions. It's part of what we do, and we're if someone, as a primary care doctor, sometimes I'll refer the patient, and the patient will literally say, well, what's that doctor going to do for me? And I'll say, well, they're going to either agree with me or disagree with me. Either way, I need their opinion. So it's okay, and then people should understand that. But that being said, if care can be given locally, it really should be. It's just the best way to provide, to take care of people. Too many times I've seen stuff kind of fall apart at bad times. And actually covering admissions over at Northern Dutchess. It's very common for people to come in with cancer-related problems, fever from chemotherapy, or whatever problem, and their surgeons are 100 miles away, and they're specialists, and it makes it much more difficult to take care of them. So I encourage people to get their care locally.
So how can you get in touch with the, is there a new breast center at Northern Dutchess, or is there, how do we get in touch with
Is there a title there, Dr. Curcio? Or is it just, we always name things. Is there a breast center at Northern Dutchess Hospital yet, or is it not given?
Absolutely. There's a Dyson Breast Center at Northern Dutchess.
Aha.
So in terms of imaging, yes, there is a breast center with 3D mammography. And that's the other thing. Patients really need to know that all mammography is not created equal. And so if they're getting their screening someplace that is not 3D, they're getting less than what would be considered state-of-the-art imaging. And therefore, either a cancer could be missed at its early stages. We believe we have state-of-the-art imaging at our facility, and we encourage patients to try it out because I think the women who work in the imaging center are caring, compassionate, and they walk patients through every step of the way.
What do we have up at the Kingston Medical Mall? I know we have, mammogram.
Same thing.
I'm sorry?
We have 3D mammogram,
Okay.
we have ultrasound, and we have breast MRI. We don't have, right now, we're not doing biopsies at Kingston.
Okay.
But so they would be referred to the hospital for the workup of anything abnormal. But we have all the screening modalities at Kingston.
So important to note, I talk to my patients all day long. Please go to the Kingston Medical Mall for your labs, for your testing, because it just makes it so much easier for me to get the results in a timely fashion. And I appreciate that. There have been many, many times where people have gotten mammograms at other facilities that have not arrived, and that's very unfortunate. So I'm encouraging people to use the facility up at the Kingston Medical Mall. Let's see, we have a little time left, and I appreciate so much having you do this. I was just trying to think of some other examples of reasons someone might go to you. Men, as they get a little bit older, sometimes get a problem where they have developed some breast tissue, right? It's called gynecomastia. Is that something that you would work up, or would you send that to a plastic surgeon, or what do you think?
So we do see patients with symptomatic gynecomastia. A lot of men will develop gynecomastia as they get older. It's related to falling testosterone levels. But some of them have, maybe like gynecomastia on one breast and not the other. So it might seem like it's a breast lump. We see patients like this all the time. We see young men with gynecomastia, particularly as they're going through puberty, or some men as they're using different products to, say, build muscle mass. Sometimes we do see symptomatic gynecomastia. And not all of it needs to be surgically managed. And there is an endocrine workup, particularly in an older male, that needs to be done to try to figure out what the cause is. Sometimes it's related to medications. So we see that in men. We see breast cancer in men. And sometimes men who have family history that are concerned about male breast cancer because maybe they had a relative with male breast cancer. So those would be reasons that we would see men in our office.
Yeah, I was two things that I would bring up is marijuana use, particularly in young men. And then as we talk a lot about the business of healthcare these days, because they took something called Zantac or ranitidine off the market, then we tried to prescribe Pepcid or famotidine, and now that's limited in supply. So we're kind of being pushed to prescribe something called cimetidine, which has a very clear side effect of causing this problem. So that's it's gotten a little difficult. Anyway, we're basically going to come to a break, but it's been excellent to have you on the show, and I am thrilled to have you as a colleague and a resource for our community. Let's see, should we give people a phone number if they want to call? Although I do recommend that people get referred, but that's okay. I mean, whatever care people need, they should get. So what is your phone number at the breast center, Dyson at Rhinebeck?
Actually, patients can seek me out and actually call if they're having a symptom, My telephone number is 845-871-3108. And we do have what we call same-day appointments. We can see the patient. Say they're having a new symptom. We can see the patient, and we have slots at our breast center dedicated to our patients, and we could potentially get imaging that same day so that by the end of the day, they would have an idea what was causing their symptoms. And we feel like that helps the primary care doctor.
Absolutely.
Kind of taking it off your plate. And it also helps the patient to get an answer sooner, because sometimes it could take them 2-3 weeks to get through the system once they have an initial symptom.
It's so important, so I appreciate that so much. Anyway, thanks for coming on the show. We appreciate it, okay?
Thank you for having me.
Okay.
Thank you.
All right, take care.
Bye-bye.
Thank you. Thank you very, very much, Dr. Lisa Curcio, for visiting us today. And this is Medical Monday with Dr. Eric Stanberg and Robin Baker. You're with us here at KCR, Kingston Community Radio, WGHQ, AM 920 and 92.5 FM, and streaming online at mykcr.org. 8:01 a.m., Monday, February 8th. And 11 degrees now here in Uptown Kingston. This last portion of Kingston Community Radio has been brought to you by Central Hudson. Weather and forecast for the next couple days. Today, a mix of clouds and sun with a high of 29. Tonight, cloudy with an 80% chance of snow developing after midnight tonight. A low of 17, 1 to 3 inches possible. And Tuesday, 90% chance of snow during the morning, then lingering snow showers during the afternoon, a high around 30, 1 to 3 inches of snow possible for tomorrow, too. We'll be right back.
You're listening to Kingston Community Radio on WGHQ Kingston. On your radio at 920 AM and 92.5 FM. And also online at mykcr.org.
Central Hudson reminds you, when it comes to your home's wiring, safety matters. Overheated electric cords or outlets are signs of inadequate wiring, within your wall, in an appliance, or both. Circuit breakers or fuses that trip often is usually a sign that a circuit is overloaded, an appliance is faulty, or something is wrong that can shock a person or cause a fire. Have a trained electrician troubleshoot such problems immediately. The Home Energy Assistance Program can help make winter a little warmer this season, with financial grants to eligible households to help pay heating or utility bills. Are you in need of assistance or know someone who is? Find out more about the benefits and eligibility requirements of the HEAP program by contacting your County Department of Social Services or by visiting the Assistance Programs section of Central Hudson's website, centralhudson.com.
Hi, my name is George Post from Ulster Park, New York, and I support Kingston Community Radio, and so should you. Where else can you speak to your local representatives on the air and have your questions answered? So thank you and support KCR.
You're listening to WGHQ AM 920 and 92.5 FM, the home of KCR, Kingston Community Radio. My name is Dan Gatus, and it is 8:04 a.m., Monday, February 8th, and 11 degrees up here in Uptown Kingston. Our call-in line is 331-9255. And this portion of Kingston Community Radio is brought to you by Herzog's. At Herzog's Home and Paint Center, community, family, and neighborhood all matter. Herzog's employees have been a part of the Herzog's family for years, valuing personal customer service and being close to their community. Stop by Herzog's Home and Paint Center in the Kingston Plaza for your home building, maintenance, and painting needs. Discover the difference of buying local. Sales ongoing at their website, herzogs.com. Let's get back to the on-air studio with Dr. Eric Stanberg and Robin Baker. And do we have any birthdays in that?
We do.
Fabulous
couple
birthday
birthdays
folder.
in the house. All right. And by the way, what a great first half to the show this morning we had with Dr. Lisa Curcio. Okay, we do have some birthdays, Robin.
Yay.
Let's see how many total. If you hear the papers rustling. 3.
February 8th.
Okay, you go first. We have 3 birthdays to wish.
So happy birthday to Oneida Negron. You're from your friends at People's Place, and we hope you enjoy and have a special day today.
Okay, and I want to wish a happy birthday to, it says Berenice Fitzgerald, also from your friends at People's Place. We hope you enjoy your special day.
And one more, wish a happy birthday to Stephen Hirsch, your friends at the People's Place. Hope that you enjoy your special day. Happy birthday. Can only be one winner, though. One lucky
I know,
winner.
but they're all from the People's Place, so maybe they could all
Yeah, they'll share it.
Yes. All right, so anyway, let's get ready.
Okay.
And this is for a famous cow pie sponsored by Boyce Dairy Milk House, 62 O'Neill Street, Kingston, New York. So when we announce the name of today's winner, please call the Boyce Dairy Milk Boss Dairy.
No.
The Boss Daily Milk House.
The Boyce Dairy Milk House at 62 O'Neill Street, and tell them you are today's winner, and you will get a famous cow pie. Anyway, today's winner is Stephen Hirsch, or Stephen Hirsch. Wow. It's kind of like the Super Bowl halftime show right here right now.
It's better. The light show in here.
All right. So, I it was such a pleasure to talk to Dr. Curcio. She really did answer questions that I have. Because, as you know, I struggle and talk about the recommendations, the fact that there are places of information, sources of information, particularly the United States Preventative Service Task Force, that recommend testing starting at 50, and how I've never really been comfortable with that. Plenty women in their 40s getting breast cancer, and I always feel like if I told a woman it could wait to 50, and a 47-year-old mother of 3, as an example, I would, and she wound up having breast cancer, I don't think that would be, that would be something I'd have a hard time explaining or feeling comfortable with myself about. So basically, she advocates for the starting of mammograms at 40 and to have them done on an annual basis. Just to rehash, when should you stop getting a mammogram? It's individualized, and it's based upon the overall health of the women, the female patient. Generally, if the life expectancy is 10 years or greater, you should continue to get the mammogram. So I usually start having this conversation with my female patients when they're in, maybe their early 80s, and generally, if they, when we get to 85 or so, we're talking about, when to stop doing it. And it's also a reminder of how important it is to have an annual wellness visit with your provider, because this is when you can have this conversation. This conversation merits its own attention and time, and it's just so important to have. I also feel, I want to encourage women to get mammograms and not be tempted by thermography. Dr. Curcio very clearly said there are no studies available to show that this is a test that's worth doing, and specifically, she said that there's no studies showing that it's more effective than a mammogram. So I guess you could choose to get it, but you still should not do it in place of a mammogram. And she talked a lot about various issues. So again, she is a local resource. I am proud to call her a colleague. Her office number is 871-3108. She accepts self-referrals, and she also tries to provide same-day appointments as well. And I find that very helpful, because this is a tremendous source of anxiety for female patients. And once again, just want to make my plea to get your care local, unless you really legitimately have something going on that you cannot get local, because there's no substitute to a primary care doctor in your community and specialists in your community, because we're the ones that are there when stuff kind of goes wrong. So I thought we would kind of segue over to our COVID update. We got some feedback last week or so that we shouldn't focus so much on COVID, which is I understand. I mean, at some point, there are other things going on, and actually that is one of the themes what Dr. Curcio and I and Robin spoke about, which is you should not delay your regular care because of COVID. We can't have a scenario where 2 years passes, year and a half or whatever, and people have delayed their mammograms or their checkups, their blood pressure checks, their routine blood work, because that's going to have its own problem. So the numbers seem to be kind of leveled off, okay? This is coming from the Daily Freeman from today. First it talks about Dutchess County, neighboring Dutchess County. The county has had 381 deaths from the coronavirus that began in March, by the way, almost a year ago. Okay, that the counties had a drop in its total number of active cases. It dropped 81 to a total of 1,186. Hospitalizations were at 123, which is down 8. And the daily positivity rate for the virus was 4.75%. Okay. In Ulster County, there have been 9,889 confirmed cases of COVID. Of those, 7,335 were listed as recovered. The active cases, however, increased by 71 to a total of 2,337. And the fatalities remained unchanged at 217. The daily positive ratio also remained at 3.8. So anyway, so I guess that's kind of a leveling. You know, numbers are up a little bit, but the positivity rate is down a little bit. And I guess that's good news. Maybe we're seeing the effects of the Christmas gatherings kind of leveling off, and that was, you know, our
right, and New Year's, but they're worried about the Super Bowl.
Of course. You know, one of the events that probably began this all was Mardi Gras in New Orleans in February.
Yeah.
And that's why Louisiana was, for a long time, one of the, states most affected by this virus.
It's hard to believe we're coming up on a year.
I know. So, Robin, you and I are fortunate enough to have both doses of our vaccine.
Yep.
I heard on the radio this morning that it's estimated that 9% of the population has had at least one dose of the vaccine. I think those numbers are going to increase dramatically over the next month. And, because now the supply is improving. Certainly got a long way to go with getting adequate supply of the vaccine. We're still having, so where can you get the vaccine, right? If you are a healthcare worker, you can get it at Northern Dutchess Hospital. You can get it at Health Alliance. There's a way to do it. We are beginning to see pharmacies administer the vaccine. I don't know if it's officially started. Maybe it will during this week or next week, but you still have to meet the criteria.
Yeah.
So what's your experience with the vaccine, Robin? How'd the first dose go?
The first dose was fine. Just a little soreness in the arm where the vaccine was administered.
All right, and then 2 weeks later you went and got the second dose. How'd that go?
I was fine overnight. And, of course, I had several coworkers who, because of working in the medical office, we when they first opened it up, we went online immediately and we were able to, luckily, get an appointment. So we all kind of were getting our second doses at the same time. And so I had the experience of what they experienced ahead of time. And I felt like that prepared me for what I might or might not experience. So I expected to be a little bit under the weather. Sorry, I'm having clear my throat here.
We have a caller.
And I ended up with a pretty bad headache, no fever, and a little bit of a chills. I stayed in bed a little bit longer that morning and was fine by about noontime. So
okay, good. And I'll review my experience with the two, and we'll try to help people sort this out. But we do have a caller. Good morning, caller.
Good morning, Doctor. Last week, your show had a lot to do with diabetes. And one thing that, unless I missed it, that I didn't get to hear was what are the standards now for blood sugar testing.
Are you referring to someone who has diabetes or
For someone who has, I have type 2 diabetes. I take metformin and I take glimepiride.
And how old are you?
76.
Okay, so you're on Medicare. Someone who's on insulin should be checking their sugars twice daily. And that is put in place by Medicare. There's a way to do it more than twice. You have to do like kind of an override. For people who are not on insulin, Medicare generally covers glucose testing only on a daily basis. Some patients don't necessarily, if they're stable, it's a plus and a minus.
Actually, what I wanted to know was what are the numbers?
Okay. So what do you mean, like a fasting number?
Yeah, I test my blood sugar every day.
Okay.
Twice a day. And I just wanted to be sure that the numbers that I think it is and the way you feel are up to date.
Generally, you want that morning number as close to 125 as possible. I think
that would be at night.
Well, what are you getting in the morning?
Oh, really? In the morning? Okay.
Do you check it in the morning?
Yes.
This
morning I tested it, and it was 97.
Okay. And did you feel okay with that?
I feel fine.
And then later in the day, you get about 125?
Yeah. Well, I test before I go to bed, and it's usually about 130 or 140 something. Last night it was a little higher because I ate when I was watching the Super Bowl.
Yeah, you and the rest of America, I know. Well, those numbers look pretty good. It's certainly a fasting glucose of 97 is very good. Sometimes they can be a little too low, but you're on metformin, which is an excellent medicine. Glimepiride we talked about last week. Some concerns about it, but if you're stable on it and tolerating it, it's okay. Do you get your A1Cs checked?
What's that?
When you go to your physician or healthcare provider, do you get your A1C?
Yeah.
And do you recall what you...
let's see. The last time I think it was about 2 or 3.
That's very good. I think your diabetes is under excellent control.
Well, I mean, one of the things. Well, actually, I walk about 1 to 3 miles a day, weather permitting, and I do some indoor stretching.
Great.
Around my house, and I'm a little overweight because I'm tempted by sweets, and but I'm trying to avoid it, and I know what the dangers of being overweight are, but it's not easy at the age of 76.
Right. There is such a thing as control that is too good. And we feel that sometimes people can be at increased risk of maybe having low sugar if we strive for too much control of the diabetes. So that would be something to watch out for if you ever had an episode of that. I think 6.2 is a very good control number, and what you reported of a fasting level of 97 is excellent.
Yeah. Oh, well, okay. But I was just I think that my question was really what is the standard for blood sugar numbers? I mean, if you test in the morning, well, I mean, I'm type 2, so I'm not on insulin or anything like that. Like I said, I'm on the medication.
Right.
And
sounds like you definitely don't need insulin. And any number below 125, I think, is excellent.
Okay. And that's even at night?
Yeah, at night it's a little, you have to put it in context of what type of day you had, because it's very much dependent on what you ate and when you last ate. I usually recommend it before dinner. So it varies, but if your level is 125 or around 125, I think that's also excellent. So, but more important is your A1C. That's 6.2. I think that's a very low number, and I think your diabetes is under excellent control.
Oh, okay. Well, thank you.
Okay. Thanks for calling. Thanks for listening.
Have a good day.
Thank
Bye-bye.
you. So.
That's great. He's doing good.
I know. There is such a thing as control that's too good. And we have to, if he ever had an episode of low sugar, which is possible, I would reconsider keeping him on the glimepiride, because again, that control is so good, 6.2. Someone's 776, that A1C could be a little bit higher and without any change in long-term goals. So. We talked about that last week when we were doing our show from home, which was interesting.
Yeah, that was a different type of day.
Yeah. So you did have side effects, and they were significant enough for you to not work the next day.
Correct.
Yeah. And when I had my second dose, I did have in the evening, who knows? I was trying to sleep, but I had episodes of chills and shakes for a couple hours. And I really didn't sleep well. And then the following day, I was pretty tired. Been achy, but it really did last about 24 hours. But the side effects with the second dose are there, and a lot of people are getting them. And when you read the side effect list, the numbers are very high of the side effects from the vaccine. That being said, as Dr. Tack has pointed out, what does he say?
He says that 25 million people have had the vaccine in our country so far, and that there has not been one fatality, whereas there's up to 3,000 people a day dying from the virus itself. He did give a great presentation at our office, Medical Associates of the Hudson Valley, last week. That talk can be viewed on mahv.net. They recorded the entire presentation, so you can watch the video, you can listen to the presentation. Just everyone was invited to come to the presentation who works at our office, and we were encouraged to ask questions. We're just regular, people that have been going to work every single day since this started, and have tons and tons of questions, as everyone does. And Dr. Tack was really, excellent in answering in great detail all of our questions and concerns.
Right.
And if I had to sum up one thing I took away from the presentation, it was that he stated in no uncertain terms, without any doubt at all, that your risk from getting the virus 100% outweigh any risk from the vaccine whatsoever. And he was like, even if you've had allergic reactions in the past, even if you have certain medical conditions, he's like, you should be much, 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 much more afraid of getting the virus than from getting the vaccine. In fact, he kind of called it a no-brainer.
Yeah.
And he went into great detail about how medicine is based on a risk benefit, and that everything a physician does is, if they're going to give you high blood pressure medicine, there's a risk. Does the benefit outweigh the risk? If they're any procedure, anything that they're going to do for a patient, there's the risk benefit. And he said the risk of the vaccine, basically, he's like, as opposed to getting the virus, the risk is negligible. So he was
right. So. I think it's important to let people know that these side effects are out there and that they may experience them, and to be prepared for them. But by no means should we allow our anxiety about the vaccine stand in the way of getting the vaccine. Again, I don't think I'm a fool. Do you think I'm a fool?
Well.
All right, you don't answer that question. But the point is, I got the vaccine twice. I don't have any concerns about it. So. I really encourage everyone to get it. Be prepared, and even, employers, I think, should say, yes, I want you to get this vaccine. I don't want this going around the office. I don't want you have to miss work because you got COVID or whatever. But I think they should say if you're having significant side effects, it's okay. Take the day off and stay home, drink some fluids, and you can take Tylenol or ibuprofen to help you with the side effects. A lot of these symptoms are caused by the immune system. The immune system is mobilizing, so that's where you get a kind of a fever and the chills and the achiness and the headache and the fatigue. But it lasts about 24 hours. And I just think we should be honest with people that it happens, and I think that will help people be prepared for it. And that's how I plan on counseling my patients.
Right. I mean, you feel a little under the weather, but you're not actually sick.
Right.
Your body is just responding, and actually it's a good thing. There were some rumors going around, Doc, that if you took ibuprofen or Tylenol before that shot, that it wouldn't have the same efficacy. Can you speak to that?
Well, the official recommendation is to not do that. Don't take Tylenol or ibuprofen before the shot in case you have side effects. First of all, the side effects may occur 12 hours after the shot, which is sort of what happened to me. So whatever you take is not really an issue. There are some theories that maybe these medications interfere with the immune response to the vaccine. I'm not really sure the data behind that. I think Tylenol is okay to take. I don't, and actually that's just what the CDC recommended. I was just right here. Where'd it go?
And also, it's good to point out too that the administration of the vaccine is virtually painless.
Oh, yeah.
I know people have talked about, they saw this big long needle and it was like really painful because people hear that the site of the vaccine in the arm is quite painful afterwards. But the administration of the actual vaccine is a teeny tiny needle. I didn't feel it at all. There was just a little, a pain in the muscle afterwards.
So the CDC clearly says if you have pain or discomfort after the vaccine, talk to your doctor about taking an over-the-counter medicine such as ibuprofen or acetaminophen. So what they're not recommending is to take it just in case, so that's the difference.
Right.
All right? We always want to mitigate side effects or symptoms of a condition.
So people are clamoring for the vaccine, Doc.
Yes, they are clamoring.
People want the vaccine. They're not able to get appointments. Do we see a remedy to that in sight?
I think the supply will be improving. I think it already has improved. We can analyze forever how this happened, why we weren't prepared to roll out this vaccine, a month ago in this manner. But I do think we'll see dramatic improvement over the next month.
I know locally that the pharmacies are going to be administering the vaccines. That should be happening soon. Mm-hmm. I know even one of our very local pharmacies, the Village Apothecary in Woodstock, was initially given 100 doses and then 200 and then an additional shipment of 700, which they very quickly administered. So I think that just keep your eyes and ears open, get your name on a list, and they're going to call. My daughter's a teacher in upstate New York, and she was on a list, and that she was not supposed to get it for a few weeks. And just the other day, they called her and said, "Can you come in tomorrow?" And she was like, "Sure." And she was able to get it much sooner than her original appointment time. So stay vigilant. And, I know as far as your doctor's office, have you heard anything about doctor's offices getting the vaccine?
No, initially I did, but I haven't heard anything. I guess the rollout is going to be to the pharmacies, and maybe at some point will be included, and we can handle them.
We've been told by the administration that we have an order placed,
right?
But we haven't heard yet about anything being delivered to us, and we have a system in place that we will be sending out a blast email to all our patients if and when the vaccine is delivered and available at the office.
Okay, and I'll be good. A lot of patients ask for it, and I don't want to criticize the good work that I think pharmacies do. There still are patients out there that want the vaccine given by the doctor's office. I really tell them it's absolutely fine to get it at a pharmacy. Anyway, we have to go to our final break of the morning. So I hand it over to Dan.
Thank you, Dr. Eric Stanberg and Robin Baker. And you're with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM WGHQ. It's Monday, February 8th, 12 degrees right now here in Uptown Kingston. And this last portion of Kingston Community Radio was brought to you by Herzog's. Herzog's has the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. Herzog's Paint and Design Center provides color samples from Benjamin Moore paints, including the eco-friendly Aura line. Color decorating consultants and expert interior designers are there on staff, ready to assist you in choosing the right colors and more. Design for your home. Visit Herzog's in the Kingston Plaza. Mid-Hudson Valley weather and forecast, a mix of clouds and sun today, a high of 29. Tonight, cloudy with an 80% chance of snow developing after midnight, a low of 17, 1 to 3 inches of snow overnight possible. And Tuesday, another 1 to 3 inches of snow possible, a 90% chance of snow during the morning on Tuesday, lingering snow showers during the afternoon with a high around 30. And again, 1 to 3 inches of snow possible Tuesday as well. And Tuesday night, partly cloudy, a low of 11. Wednesday, partly to mostly cloudy, a high of 32. And Wednesday night, a little snow comes again. 40% chance of snow showers developing after midnight with a low of 17, less than an inch of snow. And we'll be right back.
You're listening to Kingston Community Radio on WGHQ Kingston. On your radio at 920 AM and 92.5 FM. And also online at mykcr.org.
If you came across someone struggling with hunger, how would you recognize them? By their clothes? Their age? The way they speak? Would you notice a 16-year-old boy who got his first job?
Not for extra spending money, but to help feed his little sisters?
Or a mother who's in between jobs and sometimes goes to bed hungry so her kids can have dinner? Or a 14-year-old girl who signs up to every after-school activity, not to make friends, but just to get something to eat? Or a retiree who fell ill and had to choose
between getting medicine or groceries?
I am the 1 in 8 Americans who struggle with hunger. People you pass by every day but never knew were hungry. I am hunger in America.
Hunger can be hard to recognize. Learn why at IamHungerInAmerica.org. Brought to you by Feeding America, 200 Food Banks Strong, and the Ad Council.
Hi, this is Scott Harrington from Hurley, and I support Kingston Community Radio because the people need a place to have their voice heard, and it's lost in corporate radio. So please keep listening and supporting our station.
And we're back. KCR, Kingston Community Radio, AM 920 and 92.5 FM, 7 to 9 a.m. every weekday. And online also at mykcr.org. 845-331-9255. 845-331-9255. And today is Medical Monday. So any and all of your medical suggestions and questions to Dr. Eric Stanberg and Robin Baker. And let's get back to the on-air studio for this upcoming portion. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Welcome back, folks.
All right, good morning. Welcome to the final half hour of this morning's show. Good morning, Ms. Baker. What was that?
Hello.
Oh, boy. What a cheerful hello we got over there on the other end of the table. You were itching to do that, weren't you?
It was from Seinfeld.
Yes. What do you think? What do you want to talk about? Oh, we have a caller already. Okay, good morning, caller.
Good morning. I would like to talk about my accident. Okay, I've had my first shot of the vaccine.
Okay.
I had done on the 20th of last month, and I'm going back on the 17th of this month to have the other one. I had it done up in Woodstock, and anyway, we had to sit there for like 10 minutes after we had it done, and I did. And on the way home, I live in Saugerties, and I was about halfway home, and all of a sudden, I got such a sharp pain in my chest underneath my left breast. I couldn't take a deep breath every time I tried. the pain got so severe. And anyways, my friend who drove me, we stopped at CVS, in the Grand.
Okay.
Yeah. Okay. Well, anyway, the pharmacist, he came out and he had called 911. Well, then the pain had gone away. And anyway, they checked my blood pressure and stuff like that. And the first time they took it, it was really high. And then after that, it had gone down. It was still high, though. And I don't know if the vaccine had anything to do with that or not. I was just really surprised, that had happened.
How did you do in the days after the vaccine?
Excuse me?
Did you have any soreness in the arm over the next couple of days?
A little bit, very little, though. I didn't, hardly feel anything, from it, and I was surprised too, like Robin had said, how small the needle was, and, there's barely anything in the needle when they put it in.
Right.
But I didn't have any other kind of reaction, and like I said, that happened, like we were about halfway home from Woodstock when that happened. I got that awful pain, and like I said, I couldn't take a deep breath.
I always want to ask more questions. How old are you?
I'm 85.
Okay. Have you ever had something like this before?
No.
Okay.
I do have an AFib.
Okay.
But I haven't had anything like that happen, to me before. And it was, surprised me. And I had, told the EMTs that, about it, and it was one if it had anything to do with it. And he said, if I had a reaction, it would have been more like getting hives or the throat closing up or something like that.
Right.
So.
I agree with what the ENT told you. It might just seem like a coincidence, but I just don't think it's from the vaccine. It's something that you might want to talk to your primary care doctor or your cardiologist about, an episode of chest pain like that. To make sure that they don't want to do some testing to make sure everything's okay.
Uh-huh.
Did you have a primary care doctor?
I do, and I had called, but when I called, he was away, and he wasn't going to come back for a few more days, and I just spoke with his nurse about it. So she didn't seem it was necessary, more or less, for me to come in,
You have a cardiologist?
Pain, so.
Do you have a cardiologist?
Yes, I do. I didn't call him, which I probably should have.
Again, it's an episode of chest pain. It may have been nothing. It probably was, a spasm of some sort. But I just think that, your treating physicians should be made aware of it and decide if they wanted to run any tests. When do you have an appointment with your cardiologist again?
I have to make one.
Okay, that's what I would recommend to you, but I don't think it's from the vaccine.
Uh-huh. Yeah, okay, good, because like I said, I'm going to be going back on the 17th, and I'm going to sit there a little bit longer this time, even though it might just been a coincidence that happened, but just to play it safe, too,
No, I agree with that. I think that you should, the monitoring time is 15 minutes, but if we're worried, it's 30 minutes, so I think you might want to put yourself in that latter category and wait for at least 30 minutes after the vaccine.
Uh-huh. Okay, so thank you for that. And
thank you for getting the vaccine, and thank you for getting the second dose of the vaccine.
Yeah, I definitely will. And, okay, one other thing, too, here, they gave it out in the building 5 days after I had gone up there, and quite a few people in the building. I live in the senior housing on Main Street, and Neil came, and he gave it out to people here. The mayor had set that whole thing up, so... That was done, like I said, 5 days after I had it done, and they'll be coming back for the people to get their second dosages still, so.
Great. I think that's excellent. But again, let your cardiologist know that you had an episode of chest pain. I think that's something you should do.
Okay, thank you for that.
All right.
Okay,
take care.
Take care and have a good day.
All right, bye-bye.
Bye-bye.
Actually, I don't think 9% is such a bad number, to be honest with you. I mean, it could be better, but the estimate that 9% of the population has had at least one dose, that's almost 10%. And I think by the end, I think every month we're going to see maybe another 20 to 25%. So I think that's going to be good. I wanted to talk a bit about, you and I were ahead of the time. Did you know that?
Regarding telemedicine?
Yes, you and I were talking about telemedicine before it was cool.
Well, it was just a theory at that time. A year ago, telemedicine was pretty much a theory, something that might be implemented.
Well, we talked before. When we first started to do the show, we talked about this, and I remember we talked about 3 categories of telemedicine. One is a type of care that's just not available locally. I think of people in rural America who might, I think of maybe a 12-year-old who gets diabetes and they need the input of a pediatric endocrinologist, and they're in the middle of Montana, and the nearest one is at the Mayo Clinic, something like that. Or Spokane or something. I don't know. Spokane. Boise. Anyway, so that's one use, and we do that over at Northern Dutchess, where we have the services of a ICU specialist, particularly overnight, someone to monitor the sickest of the sick, people in the ICU. I think there is a role, and I'm experiencing that role, for me to help take care of my patients. The truth is that people just don't have to come in all the time, and then sometimes the appointment's simply to review some labs and maybe make some adjustment to medication or to see how someone's doing on a medication. I'm putting more and more emphasis on home blood pressure readings because I like to know what people are running in the home environment rather than the office, which could be a kind of a stressful experience. And the third category was kind of like this commercial. I see it on TV. They show some woman in bed with a runny nose, and she's talking to, it looks like it's the middle of the night, and she's talking to,
a physician on her phone.
On her phone, yeah. So I was worried about the third category, that this was, and there was an industry push. So then COVID happened, and we, out of necessity, converted a lot of our care to telemedicine. So, as we already pointed out, it's been almost a year. And, how's it going? It's time to kind of check a pulse and a blood pressure on telemedicine. What do you think?
I've had a couple telemedicine visits, and I bet you, Dan, he's on the phone. Telemedicine visits. Have you had telemedicine visits?
As a patient?
Yeah.
Yes, I've had a few.
The hiccups, I think, come from the system not working as well as it should. It's hard sometimes to get through and get that video visit to work. You could see the doctor, hear the doctor. Both instances that I had telemedicine visits, they had to end the visit and then call me and talk to me on the phone, which I was fine with. I mean, I felt that my visit went well and that I got done what I needed to do, and
that's one of the reasons I was always doubtful of the technology, because I don't see much advantage to it over a telephone call. Because other than actually seeing the person, you can't really do a decent exam. I mean, we try sometimes. Someone's trying to show me a rash on their arm.
Right.
Where I had a patient with shoulder pain, and I was having them move the shoulder around and press around for me to try to figure out where the pain was. But but for the and also one of the arguments for telemedicine was that it was going to increase accessibility, and that's good, by the way, right? I mean, and Medicare in particular kind of jumped on that wagon of allowing telemedicine. They had to kind of be strong-armed into covering telephone calls, and to this day, not really doing the same way. But who's typically going to have a hard time with figuring it out? Kind of elderly people, elderly patients. They don't even have smartphones. They don't have internet. Maybe they have a flip phone, if that. So I'm just saying. I think we're sending a conflicting message to people about that, and but I've just seen I think in some respects the shine is off of telemedicine, and there seems to be kind of the novelty is gone. I think people are. It's still a mixed bag, and I think some people still prefer the visit. But I think there are many patients who would just rather come in, rather have their blood pressure checked, rather be in the same room, and and get exam and have a nice face-to-face discussion. And I just think that, and there've been some issues with coverage, I guess, and kind of some surprise, bills or whatever.
Well, I think initially there was this push that these things were going to be free.
Right.
That there would be no copay and that there would be no
They did waive it for a while.
I think initially, yeah, they did waive it. But then, they realized that every single doctor's visit in the entire country that was happening was being waived. And they were like, hey, wait a minute here. And they quickly nixed that so that these visits are, subject to copays. And does a patient really want to pay a $20 or $30 copay when they're not being physically examined?
And it's almost a surprise bill, right? We hear that a lot it's a legal issue in a way. There are laws against surprise medical billing. So, when you go to the office, it should be kind of clear what your copay is. It's not always easy. We do have a caller. Good morning, caller.
And this is reflecting the caller's concerns.
Okay.
I know we kind of discussed a little bit about the rollout of the vaccines. There's a lot of questions. There's hundreds of thousands of people in 2 counties that we know of, Dutchess and Ulster, that are waiting.
Yeah.
And they don't know what to do.
Right. Well, for now, I think you still have to consult with the health department, and that's online. That's, again, we already talked about how that's difficult for people who are not used to this, particularly a lot of people who are higher risk for the vaccine. I'm not so sure calling the health department, is going to accomplish much, except maybe just review the instructions on how to sign up online. I think elderly people, might have children or grandchildren or whatever that can help them through this process. I would encourage them to do that. The pharmacies, as far as I know, are required to adhere to the same rules of you're eligible or not. And I did read that you have to kind of sign up in the same way and potentially choose the site to have it done. I wish I can give better information about this. This is a liquid situation. This is evolving. I think you still have to sign up and kind of review they're still kind of rolling it out the higher risk categories. It's tough in a way because so now first it was 75 and older. It's kind of down to 65 and older. I got a lot of, people in their 50s with heart problems, lung problems, diabetes, and they're saying, what about me? And I said, yeah, what about you? I mean, as of now, it hasn't been rolled out to you yet. I guess we should give a quick plug to the antibody treatment, something that we've been talking about, what's called the monoclonal antibody. This is for people who are at higher risk of getting sicker from COVID, people 65 and older, diabetics, people with kidney problems, people with autoimmune problems, people on immunosuppressive medication. And I think that this is an underutilized therapy for a combination of reasons. It has to be recommended, right? So a couple of reasons make me feel that maybe it's being under-recommended. One is people kind of getting tested outside of the context of explanation of the results. People testing themselves, home testing kids, getting tested at the pharmacy, getting tested at an urgent care where they kind of just do a quick rapid test, and that's the whole purpose for the visit, not so much to explain any symptoms for you or whatever.
Yes, thank you.
I think that there might be a lack of awareness on the point of view of doctors who can recommend this treatment, and all I can say is that I think we've endorsed it very, very strongly in our office and have had very good success arranging it for patients. So if you fall into a higher risk category and are diagnosed with COVID, you should really discuss this. We do have another caller. Good morning.
Good morning. I have a question for those that are still, suffering, recovering from COVID.
Sure.
I've talked to several friends who've had COVID or had a rough go of it, and maybe they're still home. Maybe they're listening. Have you or your colleagues prescribed Zithromax, hydroxychloroquine? I mean, there's a lot of people that I hear they have not been prescribed anything, and then they tend to suffer, for multiple weeks. Is there a stigma against hydroxychloroquine? Is that still ongoing?
I think the evidence pretty much came in that hydroxychloroquine was not effective, and concerns over side effects on the heart. But So I think we can cross that off the list. But the other the other medication you mentioned, Zithromax, I mean, that could be prescribed.
And zinc.
What's that?
And zinc.
Zinc is definitely, there is some evidence to support zinc and vitamin C to help you with the recovery of that, and that's certainly something that can be done. I would recommend Zithromax if I felt that there was some sort of, it's a pulmonary infection, and sometimes people can get a secondary pulmonary infection. So then an antibiotic may be helpful. Another thing that can be prescribed, and there's controversy about this, which is prednisone, or a similar steroid. This is particularly, usually people have an underlying lung problem like COPD or asthma, and COVID has kind of caused an exacerbation of that problem. If there's anything that seems to be helpful for people with lingering effects of COVID, I think it's the last thing I mentioned, which is the steroid. That being said, it's not a firm recommendation, and our experience to it is kind of anecdotal, and I wouldn't recommend it to everyone, but I do think it's an option for someone who is.
I've heard of tremendous rebounds, recoveries of people with hydroxychloroquine. So, I mean, if somebody is going to sit home for 2-3 weeks and be sick and not want to go to the hospital, I think it's worth, I want to mention to them, mentioning to your doctor to prescribe it, and the pharmacy does have it. So, anyway, that's my 2 cents.
Okay, I understand your perspective.
Okay, thank you.
Okay. Look, my opinion, and I think it is backed up by some studies, is that we really should avoid hydroxychloroquine for the time being. Things can change, and look, I read just like anyone else. I read, journals, medical journals. Zithromax, there are some concerns with Zithromax because it can be cardiotoxic. Zithromax, gosh, we prescribe that left and right, the famous Z-Pack, but now it's kind of fallen out of favor. Concerns over it's taken us 25 years, but doxycycline pretty much has the same spectrum of coverage as Zithromax, and it's probably a safer choice, although it's just not as convenient. You don't get the once a day for 5 days.
I mean, he brings up a good point where if people are sitting home and suffering and it's going on for weeks and weeks, just contact your primary care doctor, and so hopefully they can give you some things to help alleviate your symptoms, keep you out of the hospital.
Right.
We were going to talk about the monoclonal antibody treatment, which is only useful for people who meet the criteria, who've been diagnosed as positive with COVID. And are currently symptomatic within a certain amount of days, right?
10 days. And there's slight different criteria at the hospitals. That's treatment that's done in the emergency rooms. Health Alliance is doing it, or in Dutchess, Vassar. Vassar's criteria wants a symptom of some sort, whereas at Northern Dutchess and Health Alliance, I've had patients who just fit high risk criteria. And I think that this is the treatment, by the way, that President Trump, ex-President Trump, had in October when he got sick with COVID. It was just, in quotes, experimental at the time, but it helped him get better.
Yeah. Yeah, I just looked up a site for Ulster County. This is how to make an appointment for the COVID vaccine in Ulster County.
Okay.
And it's listing a bunch of entities that in our county that are expected to have the vaccine available to them soon. So these would be some of the places that the caller said that it's hard to find somewhere to go. So Health Alliance Hospital, the Broadway campus, Kingston Hospital. And I know if you call these places, every time I call one of them, there's an option they say before you're able to click through or talk to an operator or get to billing or whatever you want to do, they say, if you have questions about COVID-19, press this number. So they are aware that you're calling. They are ready to talk to you. So just press that. option when you call. Rite Aid at 485 Broadway, Walgreens at 316 Broadway in Kingston, Walgreens on Plaza Road in Kingston, Walgreens at 6 Simmons Plaza in Saugerties, Walgreens on Main Street in Ellenville, Walgreens on Route 9W in Highland, and the Ulster County Department of Health. So those are all listed. I Googled how can I get a vaccine today as places that are, if they don't have the vaccine right now available, they want you to get yourself an appointment and get, even if it's next week or the week after, when they expect to be getting those vaccines. So that was a few places that were listed in our county.
All right, and I wish we could give more specific instructions, but if you do, I'm sure Walgreens is expected to get a lot of phone calls about this, but they'll probably direct you in the right direction.
Yeah.
I think that if when you have COVID, I worry about getting diagnosed out of context of a thorough medical evaluation or some sort of follow-up plan. I do think if you get diagnosed at an urgent care, for example, I think you should schedule an appointment with your primary care doctor within the next week. I do think, again, we talked about a useful role of telemedicine. I think this is it. You're positive. You should stay out of the office, and we could do it from home. And this is where these questions should get evaluated. Are you a candidate for the antibody? Or do you need some other treatment like steroids or an antibiotic? The isolation period, the quarantine period, is 10 days actually. It was 14 days. Got kind of lowered to 10. Still, generally don't recommend repeat testing, although it comes up a lot. People, have employers or jobs that are requiring it, and there is a conflicting message. For example, in the hospital setting, in order for people to return to a nursing home, they have to have a negative test. So that's sending out a mixed message about the value of testing someone, even though they've been quarantined for the appropriate amount of time.
Right. When do you think it's proper to seek medical care, like at the hospital? I mean, if you're home and you're suffering with COVID and you're not getting better, do you only go to the hospital if you're getting worse?
Yeah, I think you should go to the hospital if you're having shortness of breath. And a little bit of a gray area. What does that mean? Well, if you're really, really short of breath, yes, you should go to the hospital. If you're just a little tight, a little wheezy, again, this is where, an appointment with your healthcare provider can come in. Again, we're improvising a little bit in the office, but this is a case where maybe some steroids are needed, particularly if someone has asthma or COPD, and a lot of people do. So the COVID causes an exacerbation of those symptoms. When someone does get admitted for COVID, they're usually treated with steroids. We use dexamethasone, and I was talking to my colleagues about it. Maybe Dr. Tack could weigh in why we're choosing that over prednisone or other steroids. In the office setting, we tend to just use prednisone, which is what we usually prescribe. And remdesivir is still used. That's an antiviral agent. I've read articles kind of questioning its value, but it's still part of our protocol. Hydroxychloroquine is not being administered. Still not quite sure. We have 1 minute left per show, but I'm still not quite sure of the pharmacology behind that anyway. Hydroxychloroquine is an anti-malarial drug. It also it suppresses the immune system, so it has a role with people with rheumatology problems, for example. So I'm not quite sure where that fits in. Look, if some studies are coming out, maybe reevaluating it, I'm all ears or all eyes or whatever. We've had a good show though, haven't we?
Yes, thank you so much to Northern Dutchess Hospital and the Dyson Breast Center.
Yes.
There and having that available in our community, it's such a resource for us.
Right, and yes, Dr. Curcio was such a wonderful guest talking about the importance of breast health and breast cancer screening and not neglecting it. It's such a sad story when people, whenever I hear a story of someone who's dying from breast cancer, it's someone who didn't get the mammogram. Anyway, we want to thank everyone for listening. We want to thank Robin, of course, Dr. Curcio. I thank Dan, thank the Maxwell family. We will be back next week. All right.
Thank you, Dr. Eric Stanberg and Robin Baker, for this week's Medical Monday. It's Monday, February 8th and 11 degrees here in Uptown Kingston. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley and locations near you. Thank you for being with us this morning, 7 to 9 a.m. every weekday morning. And we hope you're with us tomorrow morning at 7 a.m. for Terrific Tuesday with we've got Cameron Rylance and Nina Postupak tomorrow, right at 7 a.m., 7 to 9 a.m. every weekday. And these are inspired discussions of, by, and for the community, only here at Community Radio. And until tomorrow, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Real Country Radio.